Hi everybody, welcome back to UWorld's Next Gen Nclex review session. My name is Jackie and I'm a nurse here at UWorld. We're so glad to have you guys here with us today. We are going to be covering some postpartum conditions, so we're going to give you a crash course in all things postpartum. We're going to be covering postpartum hemorrhage, postpartum depression, and postpartum psychosis. So we're going to have questions scattered throughout, so make sure you guys stick around for those. As always, if you have any questions, be sure to ask us. We have our content experts moderating the chat. So ask away, we'll get to as many questions as we can. And as always, we encourage you guys to follow us on your favorite social media channel at UWorld Nursing. We have lots of great content for you, including our schedule of these lives, so be sure you're following us. And if you guys have just taken your Nclex and you've passed and you're letting the world know on social media, make sure you tag UWorld in there so we can celebrate with you. So we're glad to have you guys here. So with that being said, we'll go ahead and get started. Okay, so we are going to kick off today talking about postpartum hemorrhage. So we're going to pull up a table for you. Again, this is just a quick snapshot of kind of the main topics you might want to know about postpartum hemorrhage, or main points. But just to start at square one with the word postpartum, just in case anyone needs this, postpartum is going to mean after delivery. So again, we're going to be talking about all these situations that are going to happen to the maternal client after delivery of a baby. So again, starting with postpartum hemorrhage, we're going to start with our patho. So kind of what happens, what causes postpartum hemorrhage. Okay, so first and foremost, we need to know that this is an obstetrical emergency. So we need to be able to know how to identify it and how to treat it to be a safe nurse. So postpartum hemorrhage can result in blood loss greater than 1 liter after birth, and it can lead to hypovolemia. So thinking of our big picture complication, what we need to know about hemorrhage, what this can lead to. So we know hemorrhage and hypovolemia, we're going to worry about impaired perfusion to our vital organs. So think our heart, our brain. We also are going to worry about hypovolemic shock, which we know can be life-threatening. So that's why we need to know about this. We need to identify it and know how to treat it. Okay, so when we think about our causes of postpartum hemorrhage, we're going to think about our 4 T's. So this can hopefully help you remember all of this. So our first T is going to be toned. So this stands for uterine tone. So our uterus is a muscle, and we want our uterus to clamp down and shrink up after delivery. This is going to help reduce that bleeding. So if our uterus has a weak tone or it's boggy, just kind of think like weak, we're going to worry about hemorrhage. So uterine atony pretty much is what kind of we've been describing. It's like a floppy, not contracted uterus. So it's one of the most common causes of postpartum hemorrhage. So the hemorrhage is going to happen from the site where the placental blood vessels are. So it can happen when these blood vessels aren't totally clamped off. And it's going to lead to excessive bleeding. So that pooling of blood is going to make it harder for the uterus to contract down. And this is where that hemorrhage is going to happen. So we're going to talk about interventions for this later, but a good rule of thumb, anytime we're talking about hemorrhage risk in the uterus, we're going to think about something. I feel like there's memes about this about nursing school, but I'm going to ask you a question. It's just a fill in the blank. Use that chat. We're going to warm it up. So we're going to massage the what? Fill in the blank, massage the what? Let's see what you guys know about postpartum hemorrhage. Again, use that chat. Let us know. We're looking for a fill in the blank. When we have a boggy uterus, what is the first thing we're going to think to do? Massage the... I'm starting to see it come in. Massage the fundus. Good job. We'll talk about this a little bit later, but if you guys have seen some of those funny memes from nursing school about this, it'll stick in your head. The answer to so many questions in the postpartum world is going to be massage the fundus. So, all right, good job, you guys. I'm seeing a bunch of fundi come in on the chat, so good work, everyone. Okay, so first T is tone. Our second T is going to be trauma. So during delivery, there can be trauma either to in the birth canal, and that can be a source of bleeding. Our next T is going to be, so we have tone, trauma. Next is tissue. So tissue means placenta. So if the placenta tissue has been retained, meaning it didn't come out all the way, that can also be a source of hemorrhage. And then last T is thrombin. So this can be related to problems with clotting after delivery. So we have tone, trauma, tissue, thrombin. Those are our 4 T's. Those are really going to be our causes, our culprits for postpartum hemorrhage. Okay. Let's talk about risk factors. So I want to ask you guys another question. Let's use the chat. Let us know what you know about risk factors. What are some risk factors for postpartum hemorrhage? They're all going to kind of correlate in with what's causing these 4 T's. So let us know what you guys think. Good job, everyone, putting the T's in the chat. Good work, everyone. But if you know any risk factors for postpartum hemorrhage, let us know. Put them in the chat. We love to see it. Love to see what you guys know already about it. Okay, so when we're talking about risk factors, we are talking about kind of thinking about the uterus as a muscle. One of the biggest ones is going to be uterine fatigue. So think about clients that had a prolonged labor. So essentially they exercised that uterus for longer than expected to deliver that baby. Another is going to be infection. So if we had in our uterus chorio or an intra-amniotic infection, that can be another risk factor. Uterine overdistension is another big one. So the uterus grows almost too large. So this is more common when we have like situations with like twins or a larger than normal baby, or if we have fluid in our amniotic sac, anything that has to accommodate more than the uterus kind of is expecting. And then last couple factors are going to be a history of postpartum hemorrhage, and then if the maternal client has had more than 5 births, which we call grand multiparity. So good job, you guys. I'm seeing a lot of those come in. Good answers in here. Multiple babies. I'm seeing diabetes, macrosomia. That's the greater than like a large baby. Boggy uterus. Awesome. Oh, and thank you to all our friends on TikTok who are sharing this session. If you haven't done that, please do it. The more nursing students, the better. And make sure you guys follow us as well. Okay. Good job, you guys. All right, so we are going to pull up an image for you guys now. It's going to be an image of kind of what, manifestations of postpartum hemorrhage. So take a look at that. But when we are talking now about clinical features of postpartum hemorrhage, what's that going to look like in our client? Things that we're going to look for are going to be heavy bleeding. So this is going to mean saturating more than 1 pad per hour or having a passage of very large clots. Our client might also show some signs of hypovolemia. So think about low blood pressure, high heart rate, those vital signs that really indicate that our circulating volume is going down and that our heart is trying to compensate the best it can. So again, we know that combination of high heart rate, low blood pressure, that can lead to dizziness. So we'll also expect to see that in our clients as well. Okay. What are we going to do as a nurse? This is the, the most important part of what we'll talk about. Okay, so what are we going to do? Nursing interventions for postpartum hemorrhage. First things first, we need a good, solid assessment. So we need vital signs. We need to make sure we understand how our client is being impacted by the blood they've lost. So one of the first things we're going to do is we're going to instruct our client to void or to urinate. So the pressure of that full bladder, that's going to make it a lot more challenging for that uterus to contract down. So we're going to instruct the client to void. And we're also going to see with the full bladder, a lot of times the uterus or that full bladder will push the uterus to the side, and we always want that uterus midline. So that can be another reason too that we need to empty that bladder, allow that uterus to get in its correct position and start to clamp down. Next is going to be fundal massage. We talked about this earlier, but this is going to help contract the uterus down. We want that uterus to be firm and not boggy. And then if these non-pharmacological interventions don't work, we're going to move on to medications. So the medications that we're going to give, they're called uterotonics. So utero meaning uterus and tonic meaning contraction. So do you guys know some examples of uterotonic medications? Let's use the chat again. Let us know what you guys know about uterotonic medications or some examples. You can kind of think of them. Some of them are used to initiate labor, if that's helpful, a good little tip for you. because again, thinking about what they do, they contract. So that's how we're going to kind of help stimulate labor in some of these. Oxytocin, methergin, good job, you guys. Pitocin, awesome. Same idea. Good job. You guys definitely have that. So some examples are going to be oxytocin, misoprostol, methergin, and carbopro. So these are all going to be uterotonic medications. And then depending how our client's doing, nursing interventions for hemorrhage, we're going to talk about IV fluid resuscitation and maybe even giving blood. It's all going to depend on the state of our client. But again, we have to replenish that lost volume. So we can do that in some cases with fluid, and other cases we're going to need blood. Okay, awesome. Good job, you guys. So we're going to pull up our first question. I'm going to read the question to you guys, give you some time to answer. Drop your answer in the chat, and we will go from there. Okay, first question. I'll read it for you. Okay. The nurse is caring for assigned postpartum clients. The nurse should first assess the client who, option 1 is rating incisional pain as 7 on a scale of 0 to 10. Option 2 is reporting pain with urination 3 days after a cesarean birth. Option 3 has a boggy uterus and is passing a large amount of lochia rubra. Option 4 has warmth and erythema of the right breast and a crack on the nipple. All right, drop your answers in the chat. Let us know what you think. I've seen a bunch of good answers come in. Good job, everybody on YouTube. So great to see so many of you guys here today. Awesome, awesome. Good work, good work. Good job, you guys. Awesome answers. Good job. Awesome. You guys are 100% so far, so good listening, good knowledge, way to go. You know this. Okay, so that is it. The correct answer is option 3. You guys did awesome. So again, that boggy uterus, it's not gonna help us in the case of postpartum hemorrhage. We want that uterus to be firm, to contract down, to kind of clamp down. And then large amounts of lochia rubra, that's gonna indicate bleeding. That's gonna be our bright red blood. So we're gonna worry about that. Okay, you guys did great. I saw everybody had the right answer, so well done. Okay, moving on to our second topic. So now we're going to be talking about postpartum depression. So we just covered postpartum hemorrhage, if anyone's just joining us, and we're moving on to postpartum depression. And then after that, we'll cover postpartum psychosis. Okay. So quick definition starting at the beginning, and we have a table that we'll pull up for you guys too. So again, take a screenshot if it's helpful. Again, it's just the big picture topics of it all, or big picture information. Okay, so talking about postpartum depression, starting at the beginning, let's give a definition to it. So postpartum depression is a perinatal mood disorder. So perinatal meaning anytime during pregnancy, but when we're talking about postpartum depression, we're talking about symptoms that are going to be occurring around 4 to 6 weeks after birth. So it's going to happen due to these big swings in hormones. So we're going to have hormonal shifts, typically in estrogen and progesterone, that are going to contribute to this onset of postpartum depression. Okay. So question for you guys. So the next two topics we cover, postpartum depression and postpartum psychosis, they're going to be kind of on a spectrum of perinatal mood disorders, with postpartum psychosis being one extreme and baby blues kind of being the beginning of this spectrum. So what do you guys know? What's the difference between postpartum depression and baby blues? So think about what they meant, what manifestations are, the onset of time, the duration, functional ability, things like that. Put your thoughts in the chat. Let us know one piece of information that differentiates one from the other. We'd love to see it. Awesome. Oh, yep, those are good answers. Baby blues are expected. They can be, but depression is not, definitely. What do you guys know about the onset of time for it? When? Yep, okay, good job. Postpartum depression is more than 2 weeks. That's a good answer. Yep, baby blues is pretty much right after birth. And then, again, we just talked about postpartum depression being about 4 to 6 weeks after birth. So Good job, you guys. You definitely know that. Good work on the onset. Awesome. Okay, so let's kind of just talk briefly about this, and I think it'll give a good kind of understanding as we get further into postpartum depression. Okay, so our baby blues, again, this is more of like a normal, milder form of depression. It's gonna, kind of look like some emotional lability, so kind of up and down, some tearfulness, having feelings of being overwhelmed within the first few days of giving birth. So the difference with this, though, is the client's functional ability, it's not affected. So the maternal client's going to be able to carry on. And symptoms are typically going to subside within 2 weeks. So again, it's going to resolve itself around 2 weeks. It's going to run its course, and again, just some milder form symptoms of depression. Okay, so knowing that, let's talk about postpartum depression, what these clinical features are, and we can kind of differentiate the two. Okay, so again, it's largely going to look like our traditional depression, but some more specific findings are going to be related to that bonding that's supposed to be happening between the maternal and the newborn client. So we're going to see a lack of interest in the newborn from that maternal client. Or we can even have most concerning kind of obsessive thoughts of harm of the newborn. So just being overly worried about the newborn, or actually having thoughts of harming the newborn. So again, we have to kind of think about this on both sides. So postpartum depression is also going to include other findings too. So things like in the maternal client, like anger outbursts, sleep disturbances. So either sleeping too much or too little, just spontaneously crying, in like really intense, persistent states of like irritability, feelings of guilt or inadequacy, changes in appetite, most commonly manifesting as weight gain. So again, there's kind of a bigger picture of what's happening with postpartum depression. But let's talk about risk factors. So what is going to contribute to this onset of postpartum depression? First and foremost, the postpartum period is hard. So it's hard to understand how some of these findings differentiate between what's normal, what's expected, what's situational. But some of the certain things that are going to kind of tip the baseline challenges and emotions of the postpartum period into that postpartum depression situation, those are kind of the things we just talked about. Some of those situational things that can make our postpartum period more challenging. So risk factors, one of the biggest ones is going to be a history of depression or depression during pregnancy. This is, again, most likely the number one risk factor. Other things are going to be situations that kind of isolate that maternal client. So think about things like a lack of support from maybe like an unintended pregnancy, lack of support from like no family or financial strain, things like that. Even things like relationship conflict or even partner violence, and adverse pregnancy outcomes. So things like a surprise C-section, a traumatic birth, or even a stillbirth, anything like that. And then again, sleep deprivation. Sleep is so hard to get in the postpartum period, but it's so essential too to functioning and our mental health. Okay, so nursing interventions. What are we going to do for our clients that have postpartum depression? So what is the role of the nurse? So again, postpartum depression is very common regardless of any risk factors, situation, anything like that. Any client is at risk for postpartum depression. The symptoms of postpartum depression, though, they really do overlap with the kind of traditional symptoms of that postpartum period. So it's really important for us as a nurse to make sure screening is implemented in that postpartum period. So a lot of times universal screening tools like the Edinburgh postnatal depression screen will be used in that postpartum appointment with the healthcare provider. And then we also need to evaluate the maternal client for any thoughts of harm, either to themselves, to others, and really observe the client, see how the maternal client is bonding, interacting, talking about the newborn, and just, kind of look for any of those red flags that more intervention might be necessary. And we're also going to start these clients on an antidepressant medication. So think about like SSRIs like Lexapro or citalopram or sertraline. And then offer them resources for additional support like support groups or counseling, things like that. So again, we want to support these clients. We want to make sure they're safe to themselves and others, and that they have the tools and resources they need to kind of get through it. All right. that was postpartum depression. We're trucking right along. I'm going to pull up our second question. I'm seeing some really good answers and questions in here too from you guys, so good job, everyone. Okay, so question 2, this is our postpartum depression. I'll read it to you guys, put your answer in the chat, and then we'll move on to our third and final topic for today. All right, the nurse is talking with a client who gave birth to a newborn 4 weeks ago. The client starts to cry and states, "I am the worst parent in the world." Which of the following responses would be most appropriate for the nurse to make? Option 1, do you have questions about how to care for your newborn? Option 2, do you have a support system to help process your feelings? Option 3, have you experienced difficulty falling asleep or getting rest? Option 4, have you felt depressed or hopeless over the last 2 weeks? All right, let's see what you guys think. Oh, good answers coming in. Good work, you guys. Awesome answers coming in on Instagram. So good to see everybody on here today. Good work, you guys. Good answers, good answers. Awesome, awesome, awesome. I'm seeing a bunch of correct answers, so good job, everyone. I'm not going to tell you what number it is yet. And we can spend a little bit more time on this question if we feel like we need it. So good work, you guys. Good answers. And again, for anybody on TikTok, please share this session. The more the merrier. And as always, these sessions will be available on demand on Facebook and YouTube. So if you missed anything or you're just joining us and want to learn about the other topics we're covering today, feel free to check it out. All right, you guys did awesome on that. A lot of correct answers. So our correct answer for this one is going to be option 4. Have you felt depressed or hopeless over the last 2 weeks? So again, our priority in this situation is to make sure that the maternal client and that newborn are safe. So we're not going to, kind of looking at some of these other options, we really need to pinpoint if this client, is depressed and identify what their feelings are and where they are in that assessment. So we're not going to ask them about signs and symptoms of what could lead or risk factors of postpartum depression. We need to get to the, get to the facts immediately. So that's why our correct answer on that one is option 4. I saw a few people ask or answer options 3. So again, that's kind of asking about risk factors that could lead to it. But again, we need to make sure safety, the Nclex we know is a test on safety. We need to find the safest option in this scenario or in this question. So good job, you guys. Awesome, awesome answer. So our correct answer on that one again is option 4. Okay, we're in the home stretch. Our third topic for today, we're going to be talking about postpartum psychosis. So for anyone just joining us, we covered postpartum hemorrhage, postpartum depression. Now we're on postpartum psychosis. So we have another table for you guys. I'm going to pull up. So that this table, again, quick snapshot of postpartum psychosis. Hope it can be helpful for y'all. But let's talk about what happens, what the patho is of postpartum psychosis. Okay, so this is very rare, but it's so severe, and it's so important you guys know about it if you ever come across it, if you're doing any type of maternal or newborn care. Okay, so what happens with postpartum psychosis? First and foremost, it's a medical emergency. So these are all pretty emergent situations that we've talked about today. But this is so emergent because there's such a high risk of harm to the maternal client and the newborn client. We need to identify it, and we need to implement our interventions as fast as possible. So postpartum psychosis typically manifests itself within 2 weeks of delivery, and it's triggered again by those big shifts, those big swings in hormones. So it's a big decrease in estrogen and progesterone that really lead to all of these kind of changes in our brain. And then again, sleep deprivation can definitely trigger it. That's one of the big triggers for postpartum psychosis. Okay, so what are the clinical features of postpartum psychosis? There's 3 hallmark signs. What do you guys know these? I'm going to ask you in the chat. Let us know what you know about postpartum psychosis. We're looking for 3 hallmark signs. So what will our client with postpartum psychosis look like? Oh, I see some good things in here. Hallucinations, that's definitely part of it. Good work, good work. Safety risk, good answers, everybody. Awesome, awesome. Let's see. Feel free to add anyone. Yep, good answers. Hallucinations coming in. Awesome. Okay, so we'll walk through these. So the three kind of hallmark signs of postpartum psychosis, these are going to be depressive symptoms, acute mania, and psychotic symptoms. So we're going to walk through these a little bit more. So our depressive symptoms, we've talked about these with our postpartum depression. So again, think big picture, difficulty bonding with the newborn client, and then withdrawal, so being withdrawn from kind of the situation and what's going on, a lot of tearfulness. Okay, so then on the other kind of end of this is acute mania. So this is going to be abnormally increased energy levels. So think like severe insomnia, like not sleeping for days. Again, we know a lack of sleep is such a big trigger, and these go hand in hand with some of this like agitation and disordered thinking or disordered behavior. And then third is going to be psychotic symptoms. So think about like paranoid delusions, hallucinations. Most of these are going to be related again to that newborn client. And that, can look like the maternal client almost being like fearful of the newborn, or, hearing voices from the newborn, or hallucinations involving the newborn. So again, that's where all of this can kind of go awry for all of the clients involved. Okay. So risk factors, postpartum psychosis risk factors. So this can be, anything that, again, can be triggered by a traumatic birth. So think about like emergency C-sections, traumatic births, birth plans not going as intended. But one of the biggest risk factors is like an underlying mental health condition. And I'm going to ask you guys again in the chat, what is the condition, what psychiatric condition is a big risk factor for postpartum psychosis? I want to know what you guys think. Put your answers in the chat. Risk factor for postpartum psychosis, which condition? Ooh, close. History of postpartum depression, close. Awesome. You're on the right lines. It falls under this condition has depression in it, but also has another part to it. Close on schizophrenia. You guys are so close. Think of another psychiatric condition that is like umbrella for two conditions. Let's see. Oh, I see it. Yes, bipolar disorder. Okay, yes. So a personal or family history of bipolar disorder. Again, a huge risk factor for postpartum psychosis. And then again, any discontinuation of any psychiatric medications during pregnancy can also trigger this as well. Okay, so what are we as a nurse going to do in this situation? So it's going to require inpatient psychiatric hospitalization. So these clients need to be taken out of their home setting. They need to be admitted into an inpatient setting. It's going to require a lot of observation of this client and a lot of kind of medications to get them their brain reset. So some of these pharmacological interventions is going to look like medications like mood stabilizers. So think about like lithium or valproic acid, antipsychotics like olanzapine, and then benzodiazepines like alazapram for severe insomnia. So a lot of times we just need to get these clients to sleep. We need their body to rest, and that can make a huge difference. And then again, we just need to be extremely vigilant about assessing what these any hallucinations or delusions this client is experiencing. We want to keep them safe. We want to keep those around them safe. All right, so that's postpartum psychosis. We have one more question and we're in the home stretch. You guys are awesome today. All right, so we'll pull up our last question. I'll read it and give y'all a chance to answer. The nurse is planning care for a client with postpartum psychosis. Which of the following interventions should the nurse include in the client's plan of care? Select all that apply. Option 1, administer benzodiazepines to the client. Option 2, prepare the client for an EEG. Option 3, assess the client for hallucinations. Option 4, monitor the client for thoughts of self-harm. Option 5, provide the client with privacy to bond with the newborn. All right, we'll see what you guys think. Let me look at these questions you guys have on here. Good answers, everybody. Awesome. I see some questions about hallucinations. Hallucinations definitely happen with postpartum psychosis. Oh, good answers, everybody. Again, select all that apply. You're going to have more than one right answer. They're all coming in. Good job, you guys. Can definitely be tricky. Good work, everyone. Awesome, awesome. A bunch coming on Instagram and Facebook and YouTube. Awesome. And here come our TikTok answers. Good job, you guys. All right, so going over this, our correct answers are going to be option 1. So we talked about that medication. We need to stabilize the mood. We need benzodiazepines and any antipsychotic medications as well. So option 1, very true. Option 3 is true. We're going to assess the client for hallucinations. We need to understand what they're thinking so we can understand if safety is at risk. And then option 4, monitor the client for thoughts of self-harm. Again, this is a big complication of postpartum psychosis, is harm to themselves and harm to others. Okay, we definitely don't want to do 5. We want to keep that, we want to remove the maternal client from the newborn. We want to make sure that safety is first and foremost covered. And then option 2, EEG is more so done for understanding seizures, not so much this situation. Okay, you guys did awesome. Well done, everybody. So we have our schedule will pull up for you guys. So today, again, we covered postpartum conditions. Tomorrow, join us at 3 p.m. Central Time on TikTok and Instagram. We're going to be going over our musculoskeletal questions. So we'll do a question drill for you guys. And then Thursday, 3 p.m. Central Time, TikTok and Instagram will be going over, again, some more missed questions. So some of those tricky topics, we'll have some practice questions for you guys. But if you're new to those question drill sets, essentially we go through a handful of questions. We do a quick cadence, get as many questions in as possible, and really just focus on why the right answers are right. So awesome job today, everybody. As always, we encourage y'all to check us out at nursing.uworld.com. We have an amazing 7-day free trial, as well as a lot of other ways to engage with UWorld through our subscriptions, and also tons of great information to get you ready to take the Nclex for everything you need to know about the test itself. So we hope you guys will check it out. Thanks for being here today, and you can, if you missed anything, we'll be available on Facebook and YouTube on demand. All right, we look forward to seeing y'all tomorrow at 3 p.m. on TikTok and Instagram. Have a great day. Bye.